We'll talk now about the really rich data landscape that we have in the US, but I first wanted to highlight the fact that the healthcare system in the United States is really fragmented. And you can see here that you really need to understand the context of where the data are coming from. You can see that across Americans, over half of people in the United States, and the overall population in the United States is around 330 million people, so it's quite large. But you can see that most people, about 55%, have health insurance that is group-based, which is typically from their employer. And then there are smaller percentages who receive their insurance through other ways. So for example, Medicaid is a government insurance plan for lower income people. Medicare is for typically patients who are 65 years and older. The military provides very comprehensive health care for a number of Americans. There is also people in the United States who receive their care through the Veterans Administration, so these are not active military, and there are people who are uninsured still. Depending on the type of data that you are using, you may be missing certain parts of the United States population, and you have to think whether those missing people from your study are relevant for your indication, for your intervention that you're planning to bring to market. Typically, the claims databases that we use are derived from group-based insurance. So I wanted to talk first about these administrative claims databases. This isn't intended to be comprehensive across all claims databases by any means, but a couple of the ones which are used most often would be Merative Market Scan. This has been used for decades for healthcare research. The unique number of lives covered in Market Scan is almost 300 million people. As I mentioned earlier, these claims are coming from contributing employer-based plans. These are closed claims, and what I mean by that is that patient enrollment data are included, and this is really quite important for most of the studies that we conduct. When we know that a patient is enrolled in a plan, we are looking for those periods of continuous enrollment, because when they are not enrolled in a plan, their diagnoses, their treatments, et cetera, will not be captured in claims. And so we want to look in these periods of continuous enrollment and follow them longitudinally until they are disenrolled. In the US, this is quite important because there is a lot of movement across employer-based plans as people change jobs, as their spouses change jobs, as their employers change plans, because there's a lot of competitive competition across healthcare plans in the United States based on cost, et cetera. And so patients may be only enrolled in a healthcare plan for 2 or 3 years on average. And that means that we don't have necessarily the length of follow-up in a claims database here in the US that we might in Germany, for example. Optum Clinformatics is another data source of claims that is used quite often in these types of studies, in RWE studies. Covers over 60 million people from all states. These plans are commercial plans as well as Medicare Advantage plans, which are employer-based plans that supplement traditional fee-for-service Medicare plans. These databases typically capture information like patient enrollment, information from all sectors across the healthcare system, including outpatient pharmacy information about the providers themselves and other medical specialties. On the bottom, I've listed a large number of other sources of claims data. There are more than what I've listed here. There are also claims databases that are called open claims databases. They're typically larger than closed claims databases, and that can be enticing. But there's that limitation where we don't have the enrollment data available. And so we don't know if data are missing when we are looking. There are ways to work around that a bit, but just to make you aware of that limitation. And so, finally, you just need to really understand the origin of the data, that that origin of data really fits your research objectives and that you understand really clearly any gaps or limitations for your study. On this slide here, I wanted to provide an overview of some types of electronic medical records databases that are available. There are general electronic medical records databases that capture care across the healthcare spectrum, across inpatient, outpatient care, across specialties. And so one of those is a company called Triveta. It's very large. It's over 120 million people, and they do have a linkage for EMR and claims. And linkages are quite nice, as Thomas had mentioned. They mitigate the limitations that are inherent in, using claims data alone or using electronic medical records alone. The disadvantage to linking databases, particularly in the US, is it's at the cost of sample size. So your sample size will be reduced when you link two databases together. Not all patients in one database will be available in that second database that you intend to link to. Optum also offers EHR data, and this is also commonly used in RWE studies, over 100 million patients. Department of Defense I wanted to highlight here because it's a rather unique source of electronic healthcare data in the United States in that it's single payer and it's relatively comparable to what you might find in a country with national healthcare system, but it's only the people who are active military members and their dependents, so about 10 million people total. The DoD, or Department of Defense, covers all of the care for those people. And what you will find in that data is that patients are present in the data for longer periods of time than we might see in other data sources. And just to finally highlight one commonly used source of oncology electronic healthcare records, the Flatiron data sets capture data on over 5 million people. These data sets can be tumor specific, and the type of data that are captured in these databases really are dependent on the tumor type. And so some investigation needs to be done depending on your indication of interest. There are many others, of course. Again, this is not intended to be a full comprehensive list of all data sources available. And finally here, I just wanted to highlight two other sources of data available in the US. There are a large number of examples in both of these categories in the United States. So the first are registries, and Thomas gave a really nice comprehensive overview of this data source. Wanted to highlight that there are really no national registries that are available here in the US, like in other countries, such as Nordic countries, for a number of reasons. Registries typically are capturing uniform data in an observational setting, in a clinical setting. Access may be restricted to certain stakeholders. For example, we may not be able to access some of them. Really, if you're interested in registry data for a certain indication, we really recommend a rigorous landscaping and feasibility assessment to understand all the features of the databases to make sure that we're identifying any available data source that might be appropriate or fit for purpose for your study, and to understand the gaps really thoroughly. At the bottom here, I've listed a number, at least a few of data sources or registries that might be relevant for your research. The SEER data is oncology focused and has been used for decades. On the right, I wanted to highlight some surveys. Of course, you can conduct study-specific surveys, but I wanted to highlight the fact that there are a number of national surveys that are available here in the United States. They're often free to access unless you're trying to access restricted data. These data sources may include patient weights, which are quite nice because that enables you to extrapolate the aggregated data for your analysis to the overall US population. Surveys are often conducted over decades, and that doesn't mean that the same patient is followed over decades in surveys, but that the same survey is administered to different subsets of people in the United States over decades. And at the bottom, I've highlighted some examples of national surveys here in the United States. NHANES is one that has been going on for decades. NAMSIS covers ambulatory medical care. And the MEPS database captures information on the types of medical expenditures that are happening at the provider and family level.